Good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program, and welcome to today's program. Just my button forward here. Again, as you joined today, your microphones and your phones were muted, but we will be using the chat function for Q&A. So please go ahead and put your questions in there, and our entertaining team will be able to answer them. So here's the continuing medical education information. We've got our outcome objectives, the accreditation statement. I won't read it. Everyone got these in the email and when you were registering. Again, opinions expressed. You can read that. I don't need to read that out loud. Standard disclaimer. And again, you will be getting an evaluation. It'll pop up behind the screen when we're done, and I will be sending the link in a thank you email to everybody that joined us today. Especially welcome to all of our EMS and our EMT folks. We've got groups that connect in their conference room, so welcome all those teams. And for the leaders of those teams, just go ahead and remember to give me an email list of those who attended. Pretty much have everybody's email already. Make sure they can do the evaluation and get those certificates sent out. All right, again, your opinion is valuable to us. The link will come up, as you can see, and I will be sending it out in my thank you email. All right, so without any further ado, we're going to be talking about rabies today. We've got Dr. Shirazi and Dr. York. Dr. York, would you like to go on to our next couple steps?
Yeah. All right. You got this slide. All right, so thanks to everyone for joining us. If you are new to us, I hope you like what you're about to see. But we have been doing this now for quite a while, where we're focusing on envenomations, intoxications, and travel-related diseases. Most of what we've talked about in the past has been more focusing on things in the Sonora Desert. We're still trying to keep to that theme, but expanding out a bit. So again, if you're new, what we're really trying to do is cover a lot of these interesting topics that may not come up as much as we would hope, or things that you all have expressed interest in. So I'm going to show you here in a second some of the topics that we're looking to do for this year. But if there's anything that you all would be interested in, have heard about, maybe even if you want to revisit it and look at something from a different angle, we are taking any suggestions at this point. A lot of, I think, our best presentations have been composed of stuff that you all recommended for us. So please keep the recommendations coming. And again, if you are new for us or new with us, a lot of those presentations are stored on the University of Arizona telemedicine website. So you can go back and look if there's something that you are interested in. But with that said, I hope that you all are going to be very interested in this topic. I think it's just a morbid fascination in the world of infectious disease and a lot of unique things to talk about. But today we are going to focus our presentation on rabies. And to kick us off, we have got Dr. Mazda Shirazi, a familiar face around these parts, who is going to lead us in, talk about rabies, give some backstory for this, and I think share some interesting tidbits. So let me pull these slides up and we will get going. All right, pressure's on. Got it. All right.
Okay. Well, good afternoon or good morning. We are going to be talking about rabies. I got volunteered for this because the Poison Center gets the after-hour line from the Department of Health to answer about rabies. So if you have any really hard questions, I'm going to punt to Dr. Klotz and Dr. York, since they work with these issues much more closer than I do. So let's go forward. So one thing is that rabies is one of those, again, diseases that it's really feared by humans. And the fear goes back for thousands of years. And again, Egyptians, Aristotle, have referred to it. And even in a religious text of Avesta and Susa, Tasmita has been actually talked about. So this is a disease that goes back. It's been recognized as a disease, and we did not have any way to treat it for a long time or prevent it. And it's part of human history. Next slide. There is also a concern that a large portion of humanity is sort of in danger of getting exposed. And many of these countries are, of course, countries that are going through development or at different level of development than most industrial and advanced countries. And it's estimated by World Health Organization that somewhere between 50 to 60,000, almost about 59,000 here, people annually are exposed, and they actually this results in a death. Next. So rabies is a part of the, I guess, Rhabdoviridae and the genus Lyssaviruses, and it causes a direct damage to mammalian central nervous system, although the virus has also been shown to grow in some reptilian cells. Next. Here is a cartoon depiction of a micrograph, and it shows that there is the RNA. It's encapsulated, and it has various, you can think of it as receptors or protein matrices that allows it to attach to cells, especially nerve cells, and enter them. And again, this is a disease that generally is accepted that without treatment will result in a encephalitis and death. Next, please. Incubation period is interesting. It's been described to be as fast as 5 days and as late as several years. Again, that's sort of scary when you think, okay, I had exposure 2 years ago, and now I'm coming down with the disease. But usually it occurs within 20 to 60 days. Next. Common animals that are at risk of having this and transmitting are dogs, monkeys, cats, wolves. For a long time, dogs and canines in general in most of the countries were, of course, the most feared. The fear of wolves goes even further back than humanity knowing that there is a rabies. But even goats, horses, and cows have been described to contract the disease, and pretty much any mammal, including sea mammals. There's some cases of seals and such having contracted it. Next, please. Most of the world outside of the industrial and advanced countries, you see that this is associated mainly animals that are close to humans, dogs, cats, and again, feral dogs and cats are close to humans, and they live pretty much close to where humanity has its housing, its businesses, its production of food and goods. And that's where we see most of the exposures. Next. So in industrial countries, it's a little bit different. And it's, again, cats and dogs being considered more of pets. They are vaccinated and such. And there is control of the population of those animals. So we see more of the disease being caused or responsible. Animals would be wild animals such as raccoons, skunks, foxes, and bats and such. And here I have the data on that was on the US, which 90% are reported to be caused, or the prophylaxis that needed to be done were caused by bats. 33% raccoons, skunks, 20% foxes and such. And depending on the state, it a little bit changes. But that also holds for US and the rest of the industrial countries. Next. Again, same thing, raccoons, skunks, foxes, but mainly bats. And bats seems to be 70% of the rabies cases in the US over the past 3 years or so. And again, you'll find bats close to you where humans have their businesses, live, and such. And even at some of the shops here in Tucson. I've seen actually live bats on the corners and even on the floor one time. Next. So again, this is just describing that all mammals can get it, but the priority when we get a call, we try to determine what animal is responsible. So usually we ask about bats, then we go to other land carnivores and such, and then lower priority about rodents and lagomorphs such as rabbits and hares and such. But can it happen? Yes. Is it likely to cause disease? Much lower, but we get calls about these animals anyhow. Next. Signs and symptoms, again, loss of appetite, nausea, vomiting, which is not very sensitive to begin with. Then sensitivity to light, excessive salivation, agitation, paranoia. So there is some degree of behavioral changes as it advances, goes. Hallucinations. One thing that you always see in the movies and such is hydrophobia, and that's thirst, but also panicking from a sight or of fluids. Seizures and partial paralysis have been also described. Next. So there are certain regimens recommended if you're traveling to high-risk countries. And again, you can read the names of those high-risk countries by going to CDC sites for travel. But if you're traveling there, there's usually a pre-exposure vaccine. Also, people such as veterinary techs, and people who work with wild animals and such are recommended to get this. And the vaccination is usually day 0, 3, and 7. And boosters are given 2 to 3 years out. And that's what's recommended for pre-exposure. Next. Post-exposure prophylaxis, it consists of 3 different strategies. One of them is wound care and cleaning of the wound and making sure that the wound is being repaired appropriately and it's being taken care of. Administration of anti-rabies serum and then anti-rabies vaccine. Next, please. So there are 2 vaccines on the market. Here is one of them is Immunovax, and here we're describing how much it's given. It's given on days 0, 3, 7, and 14. In adults, we give it into the deltoid area, and in children, it's given in the outer thigh and not in the buttocks or gluteal region. Next. The other one is the purified chicken embryo cell vaccine. That one also is given on days 0, 3, 7, and 14. And it's given in deltoids and in other thigh. Next. The titers, 14 days after the prophylaxis, titers usually need to be 1 to 5 or 0.5 international units per mil to show that there's enough antibodies produced. Next. In unvaccinated individuals, prophylaxis, usually you get the immune globulin, which is the passive immunity, plus the vaccine, and it's you gotta pretty much inject around the site of the bite, and then the vaccine is given on those days that are described here. And it's safe in pregnancy. Sometimes that question comes, and we get that often. I got bit, I'm pregnant. Should I go in and get treated? Next. Again, the amount is for passive immunization. It's the human rabies immunoglobulin, and this is 20 to 30 international units per kg. And there is a equine or horse-derived rabies immunoglobulin, and that's for the international units per kilogram that's given. Next. Let's just go through this. This describes the same things pretty much. So the questions that we get, how to use it, and sometimes how to give the vaccine, the side effects of it, which are mainly local, again, reaction that you see, the schedule of the vaccine, and we got to go through it for the both the providers who ask that question and from also patients, and then bites that occur in neighboring countries, mainly, of course, our neighbor to the south, Mexico. And even when people come back, and if they went in and they got vaccinated there, because of ununiformity in policies in vaccination and treatment, we advise for people to go through and get the whole set of vaccination and passive immunization. So those are the things that we recommend. Next. Side effects, again, I put them here because there's lots of questions that comes about this. What can happen? That's most of them are about the site and irritation at the site or pain at the site, but you can get some enlarged lymph node. Again, anaphylactic reaction and serum sickness can occur, especially with the horse-derived products and the chick-derived products. There is some itching, there could be swelling, and some dermatitis at the site. And sometimes they can occur also remote from the site. Some neuropathy has been described. There has been convulsion and some encephalitis described, but that's not a usual occurrence, and occurs in less than 1%. Nausea, vomiting, diarrhea has been described. Again, joint pain, muscle aches have been described with vaccination and both passive and active vaccination. And then, getting some mild fever and shivering 24 to 48 hours after the vaccination has been described. Some people, again, along with dermatitis and anaphylactic type reaction, they can also develop some shortness of breath and wheezing, and we warn against that so that patients are aware. Next, please. So I put these cases here. These are some of the more outrageous calls that we got about bites that occur, and these are things that are uncommon. We had a call about a tiger bite. Of course, not only they wanted to know to give rabies vaccine and how to do it, but also how to prophylax for infection. And again, this tigers being like, we treat them like like cats and like felines, and the prophylaxis is similar to that. Three-toed sloths, I didn't know we have them in Arizona, but apparently they are private zoos, and there's one in Sedona that has them. These animals, yes, they're slow, but apparently when you bother them, they can turn around, and they have a capability of turning their head around all the way and biting you. And their mucus in their mouth can be allergenic. So I actually had to talk to the dentist of the sloth to see when was the last time he got his teeth cleaned, and the potential for rabies in this. Nile monitor, people have various pets, Nile monitors and other monitors, Madagascar monitors. It seems monitor lizards are one of the more common pets, and they tend to bite. But again, there is potential for infection, but not with rabies. And again, coyotes and Arizona gray foxes. And with those, again, the circumstance, usually if there is an attack from those wild animals, they are a potential for need for treatment for rabies. One of the recent calls we had, I think was more of a curiosity, was about a seal in California. And the finding was actually the seal was suffering from another toxicity that I think we had mentioned. It was a toxin. It was a seaborne toxin that from domoic acid that caused that animal to have an encephalitis and attack, and it was not rabies. Those are the highlights of what we get calls about. I'm going to turn it over to Larry.
Well, there goes that illusion of sloths. All right, let me get switched over here. Okay. All right, so for this portion, I thought I'd start throwing together some interesting cases just to see what should you be on the lookout for in humans? How might this show up? There's unfortunately quite a lot of cases of this that are documented in the literature. So for this portion of the talk, we'll start out with a couple, see what happens if no treatment is administered. But from there, we'll look at a couple of unique, noteworthy, or bizarre cases that I'm willing to bet a lot of the folks here may have heard of at least one of these cases, if not two of them, because one of them is very recent. But starting this off, at least when I was a kid, Old Yeller was always the thing people knew rabies. That was what we all had in our mind when we thought about this disease. More recently, the show Scrubs featured an episode, I think 2006, where the main physician in this show has just had a patient die on them. And perfect. Unfortunately that this happened, but perfect. I've got folks that need transplants. So transplants were divvied up, and all the recipients of these transplants actually died from rabies. And this was an episode that took from a real world case where essentially the exact same thing happened. Is a patient passed of, I think it was a subarachnoid hemorrhage, and organs were harvested, and I think it was three solid organ transplants, and I think a fourth person got a vessel from this individual. And all of them passed from rabies. It had completely been something that was missed. The individual, the donor in question, did mention, they said they got bitten by a bat, but had not displayed any symptoms, and I think the timing was just unfortunate. But I know a lot of folks that'll bring up, oh yeah, like in Scrubs. Not the best example ever, but a pretty noteworthy and horrible case nonetheless. But for this, we'll talk about some notable cases of rabies infections. I've got a couple of videos. I usually try to make these as much fun as I can. There is not a whole lot of fun stuff to talk about with rabies, unfortunately. It's usually seeing people in just horrible scenarios when these symptoms start to unfold. Same is true for animals. I don't think anyone wants to see animals in this level of discomfort, pain. It's a shock to see for sure. But lastly, I want to talk about this Milwaukee protocol, which I'm not sure if everyone here may have heard of this. Very controversial, arguably less so nowadays. I think we pretty well have an answer about this, but worth talking about. So, starting out, let's go with a straightforward case. This took place around 2016, 2017, part of a case series that came out of Nigeria. So, I wanted to emphasize that, as Dr. Shirazi had said, for travel, if you aren't familiar with it, or if you have patients that ask, or yourself, you can go on the CDC website, pick the country that you're looking to go to, and it has very detailed reports, not only about what's the risk of rabies, what are the animals that you need to worry about, but how does accessibility to things like the immune globulin, the vaccine, what does that look like? And in a lot of these countries, there is a risk of high probability of maybe stray dogs that have rabies and not really good access to supportive care if you are bitten. But in this case, we've got a 40-year-old farmer bitten by a stray dog, and the date was probably around January 1st, just to show a time course for what happened. So the issue here, of course, where this fellow lived, rabies PEP or post-exposure prophylaxis, not available in the local clinic. Closest one was 60 miles away. Guy thought, yeah, forget it. That's not really the easiest thing in the world for me to do. I'll do a traditional remedy. So in this case, the individual actually consumed the liver of the dog, thinking that that would potentially help them, and they even placed the whiskers of the animal along the wound. Now, it didn't take too long, a pretty textbook duration, about 2 months later, 60 days, March 1st. Patient now complains of a severe headache. They have a paresthesia at the wound site accompanied with severe pain. Now, the patient was finally admitted to the hospital, but again, unfortunately, in some of these places, there's not a whole lot that can be done. Even from my experience, I can't say every hospital has immune globulin here on hand, but usually in the city, someone's got something and it's just a matter of getting it to the right place. But in this case, all they could do for this guy was maybe some supportive pain management, maybe an antibiotic, and referred him out to a higher level of care. Now, once he got there within about the next day, fever had set in, nausea. The paresthesia was not only still there, it was much worse. Headache, but we're now seeing difficulty swallowing, hydrophobia. And doing testing for this fellow's saliva, they were able to pick up rabies virus. So, unfortunately, this fellow passed honestly within about a couple of days of those symptoms starting in. And that's going to be indicative of rabies, uniformly fatal for most folks without treatment. And once those symptoms really get going, it's not too terribly long that mortality is something that comes up. But let me make sure I'm sharing audio here. This is a tougher one to get through, but I want you to take a look at this. This is not the patient in question, but there's something very unique about this one that I am not seeing in a lot of videos of this phenomenon. So we're going to see a fellow here trying to take a drink of water who has rabies and symptoms have entirely set in.
Recording. Okay.
So honestly, what is noteworthy about this case that I am surprised that this individual was even able to swallow that water. So the hydrophobia where a lot of this is coming from is from horrible spasms that is caused by essentially the virus just starting to destroy these folks' brain neuron connections, all the responses that folks get really start to suffer once the encephalitis sets in. So even that exposure near water, you can get that onset of the spasm, even just that thought. Even aerophobia is something that you may have to be worried about for some of these folks here. Let me pause this video. Or even a breeze that comes along can trigger this response. Now, if you're curious, there are, again, unfortunately, a lot of videos of this phenomenon. Most folks cannot even get as close as this fellow did to getting a drink of fluid. Usually, it almost is a full body, an aggressive response. Children that have rabies, pushing it away, hiding from it. It's a very severe response that starts to manifest with this. All right, now looking at our second case, let's bring in an animal component to this and talk a little bit about that. So the patient in question had just gotten a brand new puppy within the last day or two. Now, day one, getting this animal, two of the neighbors were bitten in addition to the owner. Now, more what was happening here was people were fine, but the puppy was just displaying a poor appetite. So it was brought into the hospital to be checked. Now, by the time this animal had already been brought into the hospital, its behavior was particularly aggressive, which is also something we'll talk about. Uh, Again, the old Yeller phenomenon, noteworthy, unfortunately, with animals that might get this. But the owner, very attached to the puppy, would not allow for it to be euthanized. So the animal was kept sedated, put in quarantine, and just monitored, which is something that you will typically see with animals of lesser concern. So, for example, in Arizona, cats and dogs may just be observed to see if anything happens to them over the next 10 days or so, whereas maybe an exposure to a bat or a skunk would be more significant. Maybe something would be set in motion more quickly. But at the end of the day, the symptoms seemed more apparent what was probably happening. All of the bite victims were referred to come to the hospital for post-exposure prophylaxis. Now, this I think brings up another interesting aspect of access to care. But the puppy actually ended up passing within 18 hours once it was brought into quarantine. Not a lot of information on the time course, the behaviors prior to this owner getting it, but certainly once these symptoms had set in, it was very quick before they passed. The brain was extracted. They were able to confirm there is rabies in here. The owner was informed of the results. They knew that this puppy that had bitten them had rabies. The two neighbors absolutely came in and got treatment, but the owner declined. Now, I think what's of interest here is they declined because of the cost. They couldn't afford it. This too was out of Nigeria. At the time this happened, it was about, I think, 68, 69 US dollars for this treatment, and they simply couldn't afford it. Now, unfortunately, you can probably see where this is going. 5 weeks later, the owner presents with symptoms, fever, right hand paresthesia. So you're going to see that recurring trend that where the wound takes place, paresthesia is pain, not at all unusual. Difficulty swallowing, hypersalivation, even in humans, this is something that is observed. We're going to see evidence of this in one of our later cases. Dyspnea, a lot of folks do end up having to be intubated for supportive care, and the hydrophobia did present itself. So, unfortunately, this person passed within 2 days of admission to the hospital for treatment. So, this that I'm about to show you is going to be, I think, maybe a more unusual presentation than what you're expecting for animals with rabies. So, we do have a little bit here, of course, taken from YouTube.
This is a rabid dog. He's been out here for a while, and you can see he is foaming at the mouth. It looks like he was involved in an attack, but anyway, this is what they look like. So, not a joke. This is a serious situation. We call animal control, but anyway.
I'll pause it here just for time, but essentially this just continues on in the video. Now, I think this is one illusion that a lot of folks have is when we think rabid animals, we think furious, aggressive, attacking individuals, and that absolutely is true. But when we look at especially more dogs, you tend to see three consistent phases. There's a prodromal phase. For me, I feel like it's a little bit harder to characterize. I tend to think of it as almost the inverse of the animal's normal behavior. If they're quiet, they tend to be more aggressive. Otherwise, they might tend to be more lethargic, but usually an awareness that something is off. Now, that may last for a few days. The second phase tends to be more the excitatory or essentially the furious phase. And even for this, I really couldn't muster putting up videos of that. There are quite a few. But essentially, they all boil down to if you can imagine what it looks like for a wild animal or a dog to go absolutely nuts and tear into folks, that's what this starts to look like. Is you get animals hypersalivating. This may overlap then with the third phase, which is likely what we're seeing here, and that's more the paralytic phase. So the third and usually the end stage phase, a lot of folks will call dumb rabies because the animal may behave just like this. Now, even knowing that, I would warn everybody, we don't know that that's what's going on in this case for sure. For all we know, this could be a prodromal phase, and at any moment, this animal could absolutely go into the furious or the vicious phase. So always be careful in encountering something like this. Unfortunately, there's nothing you can do, especially at this point if we are to assume this is the paralytic phase. So looking at the owner's pet, likely we were seeing them in maybe that more furious phase, but again, once they were taken, put under sedation, who knows? All right. So those are two basic cases that you might be more likely to see in humans, and I think some of the takeaways, paresthesias at the site, and for the sake of time, I don't have here, but of course, for your own practice, the site where the wound takes place is absolutely of importance. It's if someone's bitten in the finger or the hand, it may take longer for those symptoms to develop. Essentially, the closer you are to more central nervous system, probably the worse off you are. We're talking folks that may get bites more in the neck, in the head, probably much higher risk than someone maybe getting an exposure on their finger. But with that said, we have a case just so, and this is a particularly unusual one, also very recent. So, especially in the world of ID, this made waves, and you could probably see where this is going, but I think it's an interesting one to talk about, and the paper is fascinating. So, this was an 84-year-old man awoken by a bat biting his hand. I can't say I can imagine what that's like, but that absolutely sounds like the stuff of nightmares. This guy and his wife lived in a log cabin. It was not unusual for them to have critters that would occasionally get in, but this probably takes the cake for me. This sounds awful. So, to his credit, this guy did everything right. The animal did perish. He brought it in with him. They had the physical specimen. And what they decided to do was, well, all right, let's go ahead and we'll test the animal. And if something comes back positive, we'll go ahead and get you set. We'll get the immunoglobulin, we'll get the vaccine going, which is something that can be done depending on the region. I believe this was Minnesota, but don't quote me. A lot of these unusual cases are Minnesota. I believe this one is too. There's been a couple weird ones. But they just waited, and then once the test came back positive, they went ahead and administered the treatment. So just as Dr. Shrazi had said, the immunoglobulin, you go ahead and get your dose. You infiltrate as much as you can around the wound for that direct activity. And then once you've essentially done as much as possible, you go ahead and administer that at another site, usually a farther away site than if I go, wherever the wound is, maybe I'll do the deltoid, maybe the thigh, but getting it away from there. But as Dr. Shrazi had said, you don't do some of these things in the gluteal muscle. The concern there is based on some older studies. It just seems like it's not as effective. There have been folks that may get some nerve injury from getting it done there. So essentially anywhere but the gluteal muscle for some of these injections. And in a lot of these studies, that is something that is taken note of, that there's worries may have contributed to failure, is folks not aware did inject in that site, and it may have led to a lower effect or a diminished effect. Now, the vaccine, again, this guy did everything right. Everything was done right. He got the vaccine then and there, day 3, day 7, day 14, done. Now, the wife who was in the same room did not report anything unusual, but went ahead and got the treatment just as the husband did, just assuming there could have been an exposure. And looking at bats, I've got a picture near the end, especially for folks that may not have the best vision, even if your vision rocks. The wounds that you may get from some of these bat bites are so insanely small, there may not even be blood, can be very easy to miss. If this person had just woken up and seen a bat on his bed, there's even an argument, would he have known he had been bitten, even if looking at the site can be very easy to miss in some of these circumstances. Now, you can probably guess where this is going, and it is indeed where you think it's going to go. But how? How could something like this happen? So let's follow the quick course here. January 7th, so now it has been about 5 months from when this occurred. This guy has now got very painful right-sided facial paroxysms, right eye lacrimation, pretty excessive. 2 days later, gives in, goes to the ED. Now, ESR is elevated, they checked this, but at the end of the day, it was thought to be trigeminal neuralgia or temporal arteritis. Anything else that can explain that constellation of symptoms. Was rabies considered? Sure, but because that he had done everything right. And if folks get treated early with the right treatment, it is extremely unusual to see folks that would have symptoms, or usually this works. It works very effectively. Now the symptoms persist. He is going through all of the legwork trying to get a temporal artery biopsy done, but he gives up. Goes back to the ED on January 13th, facial paresthesia, dysphagia. He's got some myalgias, paresthesias on the right arm now. Again, discharged. Still thinking, all right, still this is probably trigeminal neuralgia, but you're on oxycodone for the pain. That's probably what is causing the nausea. Here's some ondansetron. Here's some Zofran. Again, the symptoms continue to get worse. In decreased oral intake, secondary dysphagia. Now we're seeing right-sided paralysis. Imaging seems to be negative. A biopsy actually is done of the artery, non-concerning. Now, okay, could this actually be rabies in this case? Now, January 15th, CSF shows a lymphocytic pleocytosis, more suggestive of probably a viral encephalitis. Finally, having issues with oxygenation, intubated. A fever develops January 16th, never goes away. Care is finally withdrawn on January 22nd. Sample done from the patient. Then January 26th, the CDC confirms that yes, this was rabies. So what the heck happened? This is unheard of. The final comment from the study, and this paper is written by the folks that conducted the investigation. It's fascinating. Host-mediated primary vaccine failure that results from an undiagnosed immunosuppressing comorbidity is the most parsimonious explanation for the patient's fatal outcome. When checked, the rabies antibodies in the serum and CSF were non-neutralizing, did not seem that even despite treatment and the vaccination, this person was really able to mount any kind of a defense. During the hospitalization, it was observed that he had an IgM monoclonal gammopathy of undetermined significance. Weird, but until the autopsy was done, it was not known that this individual had an unknown prostate adenocarcinoma and there was metastasis to the bone marrow. So, in essence, this was an immunocompromised person. It had been missed. So, as Dr. Shirazi stated, if we had known, could there have been something that maybe we could have done? I mean, it's armchair quarterback. Who knows? Arguably, yes, there were things we could have done. It is recommended to do a fifth vaccine dose, as he stated at day 28. Now, another thing that the CDC will additionally recommend is potentially checking those titers just to make sure that, all right, I've done everything, but do you actually have a response to this? The other thing, too, is with folks that are immunocompromised, in some of these cases where maybe it's lesser concern, it might be warranted to go ahead and just start the immunoglobulin, start the vaccine is in a lot of these cases. So that transplant case, for example, I think all of those recipients died within 13 days or around there of getting those transplants. There's evidence that maybe immunocompromised folks, as you could guess, will succumb much more quickly to these infections. So this is just to reiterate, easy to miss these stinking little buggers if they bite you. It was a silver-haired bat. The question raised was, well, 5 months had passed. Couldn't this have been from another exposure? No. So because he had kept the animal, they were able to show it is the exact same rabies virus that's in this bat as is in this guy right now. But if you can't see, I'll be honest, for probably 48 hours, I thought this stupid little triangle was the bite. No, it's pointing to the actual bite, which is this almost imperceptible dot in this guy's finger. Just emphasizing, easy to miss these stinking things. Now, for the sake of time, just to make sure we've got questions, I have one last case. This is the one that I think a lot of folks will probably have heard of. I know even 20 years ago in undergrad, this was being talked about in school. So the preface for this is new treatment discovered, but we'll get to that. So famous case, her name's coming up actually this year. It has been 20 years since this happened. 15-year-old girl bitten by a bat at a church in Milwaukee. The bat was in the church, someone swatted it down. This girl loves animals, so she actually asked, can I just go take it outside? She took the bat outside, tried to put it in a tree, and upon putting it in the tree, was bitten. Now, the bat seemed fine otherwise. There really wasn't concern at the time, so nothing was done. There was no PEP administered, no vaccine, no immunoglobulin. But after 1 month, fatigue, paresthesia of the left hand, that's where the bite took place, set in. Now, how I've got these bullet points divvied up over the next few days is what happened each day. So then the next day, diplopia. The next day, nausea and vomiting. The next day, blurred vision, left leg weakness. The next day, fever, slurred speech, nystagmus, left arm tremor. The final bullet point down here, she was intubated after issues swallowing, but also hypersalivation at this point was setting in. So the parents were given the option. We could do hospice. Let's be honest, once these symptoms set in, it's pretty well a done deal. Or we can try something. And the decision was made, let's try this crazy approach. So I've got the exact protocol that they followed in this study. They administered ketamine and midazolam. They were targeting a therapeutic coma, and they've got the specific rate there. They would do transfusions to keep the hemoglobin at a certain level. I've got the ventilation stats, DVT prophylaxis. But in addition to the ketamine, the midazolam, it gets weird again at the end. Ribavirin was administered here based on in vitro speculation that maybe this is going to work against rabies virus, in addition to amantadine. And amantadine, maybe a double whammy here that this was more an anti-excitatory drug that might help some of these issues that the individual was having. Now, a number of other things. This is an interesting case to look at. Some metabolic derangements. The midazolam had to be switched to a version that had some benzyl alcohol. Eventually, there were metabolic issues from just overload of that drug. Using phenobarbital as supplement, an interesting course. About here, maybe SIADH, but this is the first really known case. This person recovered. And to be quite honest, the level of recovery is shocking for this individual. So she did eventually leave the hospital. For the sake of time, I didn't put any videos here. But if you're curious, this individual's well known. You can find her very easily. Look at how she is presenting upon leaving the hospital. A lot of movement disorders, a lot of hindered speech. But following this individual, the chorioathetosis completely resolved in the next 1 to 2 years. Now, she had ongoing gait difficulties, some fluctuating dysarthria. In the more recent times, I don't know that she's really publicly stated a lot of the things she may still have issues with. I believe she is still doing some physical therapy for some of these issues. And there is some video of, you can see her running, walking. I believe she listed more to one side. The noteworthy thing is there was no apparent change in her cognitive function from before the infection. She was able to drive, she was able to do activities of daily living. She went to college, she scored above average on entrance exams. Essentially, a remarkable discovery, and a lot of it was attributed to this so-called Milwaukee Protocol. Now, let's talk about this, and this will be the last thing we mention. I want to make sure we get some questions in here. I don't want Dr. Klotz to feel too lonely over there. Gotta make it worth your while. But modifications were made to the Milwaukee Protocol over the years. Let's be honest, this is an untested thing based on speculation, on theory, as patients would present with these symptoms. I can acknowledge if you got symptoms of rabies, you're probably done. This is going to be the end. So I can see the logic in the kitchen sink approach. If that's what is awaiting me, why not try everything I possibly can? I can appreciate that approach. But essentially, this thing was just tinkered with, and there really was not significant data supporting a lot of these things. They added in monitoring and trying to prophylax against cerebral vasospasm, nimodipines on there. And I've got a table here. There's a great review article that highlights all of the pieces of this Milwaukee protocol and honestly debunks most of them, or at least argues against them. But the truth is, there's a lot of controversy about whether this even works. I mean, it's easy to say when you've got a miracle case like this, the first time someone's not gotten anything and they made a recovery. But a lot of the recent studies actually suggest a lack of efficacy, so much so that a review, or not even a review, an article written about the girl just talking about her life, like kind of following her in 2008, even as late as March 31st of this year, have gone back and retroactively added, yeah, based on the current data, the Milwaukee Protocol is not recommended. So this particular study, this individual, Jackson, has written a couple of papers that I think are really interesting, clearly a critic of this, and I think makes some really good points. But the main things here is, are you really helping anything by inducing this therapeutic coma, by administering amantadine, ketamine, all of this stuff? Are you doing anything? And on the flip side, the thing that a lot of people want to acknowledge, I think, are you harming them? Are you actually making things worse? And there is an argument to be made about adding to neurologic dysfunction by doing some of these things. So this is small, but I wanted to make sure it was on here for all of you so you can pull these slides later if you're curious. If not, I've got the exact study here that this is pulled from. You'll notice this is a paper of all known 29 cases, and this was around 2014, United States, Canada, and the UK, of people that had supposedly been given this Milwaukee protocol, and there was at least data to follow what happened to them. Now you'll see here, 2 people survived. All right, we got another miracle. Maybe this works. Very controversial, and the argument here is those folks never really seem to develop neutralizing antibodies. There is an argument, did they even have rabies to begin with? And in one case, it seems more clear, probably not. This is probably not rabies that you're actually dealing with. So a lot of argument about how valid this protocol is. But really, at this point in time, now admittedly, there's not really a rabies treatment guideline. The best we can do at this point is prophylaxis or the immune globulin in the vaccine. Once these symptoms have set in, it does not appear that giving the immune globulin, the vaccine, do anything. On the contrary, based on some fairly old models out there, mouse models, maybe giving this stuff during the symptomatic phase will actually make them worse, paradoxically. So once the symptoms have set in, that's likely it. But all of these criticisms really argue just the basic critical care was probably the thing that was the most efficacious part. Doing what you would do for anyone experiencing the particular abnormalities or dysfunctions, whether it was rabies or not. Yeah, it probably is beneficial, is throwing in this therapeutic coma, the amantadine. Ribavirin was eventually dropped, thankfully. I hate that drug if we don't have to do it. Particularly toxic, and this individual did have some issues with it. Are we doing anything with this stuff? Or maybe making things worse? So the general conclusion now is that the best approach is exactly that, not doing this Milwaukee protocol, doing exactly what Dr. Shirazi talked about and giving the globulin, the vaccine. And if symptoms develop, basic critical care, whatever intensivists out there would do, that's probably the best thing to do at this time. The Milwaukee protocol has never really been studied. It's something that is done by folks that may be more clinically experienced with rabies or folks that feel that they have no real options left. And while, yes, we can't definitively say there's no benefit, there is the potential for harm, and there's really no data supporting its use. So officially, it's not recommended at this time. So in conclusion, I would say have a lower threshold for immunocompromised individuals. Certainly, if someone comes in and they've maybe been exposed to a bat or a skunk, I might start right away in getting those folks treated, which really is more the recommendation in Arizona. Don't forget that extra vaccine and don't be shy. You can check the immune response. Additional doses can be administered. Usually at that point, it's done in conjunction with the CDC. Again, timing is critical. Once the symptoms have set in, that is probably it. Now, the last thing I will say here is there's actually some really interesting case reports out of India that are supporting just basic critical care is being the thing that gets folks through the worst of this. Also, be aware when you're seeing definitions about rabies survival, there's a lot more represented than I think when you really look at the cases you would feel represent rabies. What I mean by that is you've gotten through the rabies symptoms, but you die of something else while in the hospital. That definition, I think, gets a little bit muddled in some of these cases too, where folks not having maybe the hypersalivation get written off. Well, oh, they died of herniation or something. Something else did. It wasn't rabies. So something else to be aware of too. All right, so let's see if we've got any more questions. All right, so a question for you, Dr. Strazi. Are you seeing more cases on the rise, at least in Arizona and maybe in the US?
Not that I can say that we see more bites, and it has to do with, we have more people going out in wilderness. We go, people camping, and in general, also our housing sort of encroaching on wilder areas of our lands. But not necessarily seeing higher number of cases if we don't account for those things.
Gotcha. All right, next question. Best advice you can give patients in the field. The thing I didn't mention for mine to focus just on the presentation is I think it is really worth not overlooking appropriate wound care. There are some cases, there's some reports, India's got quite a lot of this published, where everyone did all the right stuff. They got the immunoglobulin quickly, they got the vaccine, and it's thought that this may have failed because wound care was not all that great, and maybe there was still residual stuff left there. So again, advice, just identifying what the animal is, really being sure to get that history. What happened? What was your encounter with the animal? I know we've had cases where kids have been left unattended briefly and were found with a bat nearby. Getting that full story is key. But certainly immediate treatment if you feel that there is risk. Where did the bite occur? Taking stock of all of this is critical. All right. And then another comment here. So shots in the stomach, still the thought non-medical professionals think of with rabies. I don't think so. I do tend to think of probably not pleasant shots at the site of the bite, which I can only imagine are awful. And then the residual usually going maybe deltoid, thigh. I tend not to think of stomach, truthfully. Do you
Well,
see
it used to be it was an alternative. I had, as a child, I was bitten by a Dalmatian that no one could find and ended
Jeez.
up getting duck embryo vaccine. It was 14 shots and they were all administered all around the abdomen because they'd get sore. And then on top of that, I got serum sickness from the immunoglobulin, from equine immunoglobulin. So
Jeez.
it was a real treat.
Oh,
And,
goodness.
Mazda talked about that tiger. Actually, I had people when I was at KU, University of Kansas, they called from Wichita, and there was a tiger that bit some guy. So I administered the vaccine to that character. But the one that was the worst, and it proved to be absolute rabies, was a bite on a farmer from a donkey.
Oh,
And
jeez.
however, I'm not sure that donkeys can transmit it. This is one of the crucial aspects of all these animal series of going through. Like rabbits can get it and they will die rapidly, but I don't think they can transmit it to humans. And the same might be true of donkeys. I don't know, but I sure wouldn't want to be bit by a donkey.
It's wild that even this many years later, we still don't know a lot of these things about what can happen with it. I
Now,
think that's why
we
it's
see lots
fascinating.
of horse and we see also sometimes donkey bites. And most people forget that these animals can actually bite you, and their bite can be pretty severe because of the size of their mouth. They can actually take a pretty big bite, and they can be painful. And if it's on the shoulder or elbow, they can actually do pretty good damage. So we do see bites from them, but transmission of the rabies, usually we don't.
Yeah, it's kind of interesting because that's the way Pasteur developed his vaccine for rabies, which was effective and saved several people's lives. And that was by infecting rabbits directly from rabid canines. And then he'd pass it through different rabbits until they became almost resistant. And then you'd start giving this chewed up central nervous system tissue as the vaccine. and it was successful. So it's pretty unusual, the whole. What exactly is in the vaccine, Mazda? Is it
I am, to be honest with you, I'm not sure.
killed rhabdo?
But it appears to be, yeah,
Rabies?
it appears to be killed because we can give it also to immune compromised people. So it's a modulated vaccine. It can't transmit.
Right, right. I knew it didn't do that, but I wasn't sure exactly what's in it.
I'm not sure either.
Between the two, other than cell cultured vaccine, I would have to look on that one. All right, so we have gone just a hair over time. I think we've got all of our questions. So again, for all of you doing the evaluation, let us know if there's something else you want to see us talk about. But coming up next, we're going to get back into rattlesnakes, so be ready.
All right, and that's coming up in May. I believe it's the 14th. We've got quite a few people that have already registered. I'll have that information in that thank you email to everybody, along with the evaluation link and copies to the recording, which will get posted up later today. Thank you again, everybody, for joining us, and we look forward to seeing you next month. Take care, everyone.
Bye.
Bye.